standard setter for targeted radionuclear therapy, helping countries translate science into capacity on the ground, building skills, quality systems, and regional collaboration so that no nation is left behind. Secondly, SCK-CEN, Belgium's nuclear research center that serves as a catalyst that converts scientific insight into platforms, infrastructure, and expertise that enable targeted radionuclide therapy to scale. Also, PanTera builds the industrial supply of key alpha emitters such as Actinium-225, transforming micro-scale research quantities into dependable production, which is indispensable for clinical use. The Institute Jules Bordet advances clinical research and trials that generate the evidence regulators, clinicians, and payers require so that therapies are certified, trusted, and adopted in daily practice. And last but not least, of course, the Oncidium Foundation, which is a well-established non-profit organization with a proven track record, mobilizing an international network to expand patient access to targeted radionuclear therapy, prioritizing underprivileged communities, and delivered education and hope. And as you've seen, probably the DG has already tweeted about the signing of the MOU he had between the Oncidium Foundation and IAEA yesterday. So all these players have complementary roles that connect seamlessly from the molecule to medicine and from facility to patient. The program today reflects that continuum, and I thank, of course, our moderator, Professor Erik van Walle, and each of our speakers for guiding us along it today. One final word on why does this matter here and now? Because targeted radionuclide therapy already delivers meaningful options for patients with limited alternatives, yet access remains uneven. The answer to that is partnership. Belgium brings research excellence, manufacturing know-how, and leading clinical centers. The IAEA brings convening power, standards, and capacity building, and the foundations and the industry bring agility, resources, and a focus on outcomes for patients. Together, these strengths can shorten the distance between a promising radioisotope and a life extended with dignity. So on behalf of Belgium, I thank the IAEA for its steadfast partnership and each organization represented here for their leadership. I invite you to engage actively, to ask practical questions, and to identify the next actions you can take all together with us. I will now invite Mrs. May Abdelwahab for the speech as a High Representative of the IAEA. Please, May, you have the floor.
Thank you very much, Excellency. And we, as Director of Division of Human Health, I'd like to express our appreciation to Belgium and Oncidium Foundation for organizing this important and exciting event, and for the institutions around the table for their support against pressing health challenges. So if we take a step back, for example, we look at 2045, and what we expect is the global cancer incidence will rise significantly, surpassing 30 million new cases and 17 million cancer deaths. Advances in the oncological armamentarium, like radionuclide therapy, offer hope because it's targeted and precise. Of course, there's a differentiation between high-income countries and low-middle-income countries in terms of access, and that can be quite challenging. And I'll give some examples, not only in the availability of radionuclides, which is very clear if we look at some of the maps from the Lancet Oncology Commission on Theranostics and Radiotherapy. We look at the physicians, for example, that are going to be delivering this, and we know that high-income countries can have 10 nuclear medicine physicians and 5 physicists, 40 nuclear medicine technologists for 1 million people. But then low-income countries will have 1 of each for 10 million people. That's amazing. It means that the access to care is not going to happen not only through production, but also we have to have training. The equipment, for example, is another area as well. If you look at, in addition, SPECT scanners, 55,000 people for one scanner in high-income countries. In low-income countries, 20 million people use that one scanner. So we really have a lot of issues, including also in PET-CT, the same thing, the same pattern, 300,000 people for one scanner in high-income countries, but 100 million in low-income countries. And in many countries, there's nothing there at all. But in spite of these statistics, we know how beneficial radionuclide therapies are. And I'm preaching to the choir right now. We know that health economics modeling of treatment, for example, for prostate cancer, shows that a social impact totaling 725 million over a 7-year period. And the reason I'm choosing prostate cancer is because we have recent studies showing that this can help the most difficult prostate cancers that are resistant to all kinds of treatment. So imagine the impact, even in a difficult situation like that. So in addition to that, a comprehensive scale-up of treatment, imaging, and care quality could lead to $2.66 trillion in benefit, $12 per dollar invested. So there's value. The humanitarian aspect is important. We all care about that. That's our number one choice. But we have to think of the economic aspect, especially when producing these radionuclides and also when delivering care and setting the infrastructure for it. So that's why, of course, the IAEA has been working very hard to increase capacity in radionuclide therapy. And with your help, we hope to see a much brighter future for that. And we'll hear more from our panelists about this, whether it's investigating safety and efficiency and producing guidelines, all of the things that we've done. You'll hear a little bit about that as well, and training of experts and so forth. We've also, the IAEA has also expanded nuclear medicine services. You've all been involved or heard about some of the projects that have been going on at the national and regional level, as well as, of course, very important, the infrastructure, the regulatory infrastructure, to be able to deliver what we want to do. And safety guidance and support for production of radionuclides. All of these factors are supported as well. And finally, we work with many professional organizations, expanding the knowledge and being able to arrange professional development activities for low and middle income countries. So finally, under Rays of Hope, we have amplified our efforts in bringing this much needed care to communities around the world through our network of anchor centers that trains people and provides experts and expert missions and other things, and through the projects, country projects that implement some of these activities. Changes happened in many places, including Africa. But of course, we can't carry out our work alone. That's why partners and support, like the Oncidium Foundation and Belgium in general, and many of the institutions around the table, are essential for us to be able to have an impact and complete our mission. And together we can realize the promise of nuclear medicine and technologies as well. So I wish you a successful event, and I thank you very much for putting this together.
Thank you, May. So I'm Erik van Walle. I'm the co-founder of the Oncidium Foundation. We founded Oncidium in 2011. And I'm also the vice president of Oncidium. It's my honor now to introduce Peter Baten, who's the director general of SCK-CEN. And as you can see, he will talk about the institute, which is called SCK-CEN, my former institute, how it can be a catalyst for targeted radionuclide therapy. And of course, not only in Belgium, I think also a little bit abroad. Thank you, Peter.
Okay, thank you very much. So, was preparing this presentation.
Mike.
Okay. So they came up with 38 slides, which is, of course, not corresponding to what you have been asking, 10 minutes. I tried to reduce to 18, but okay. We will see how far we get. There's a timekeeper anyhow. So, okay, so SCK, we have defined our strategy around 3 main domains. And you see that one of those 3 domains is indeed the fight against cancer, which is in fact what we are talking about today. So it's really in the heart of the strategy of SCK-CEN. Now, why is that? It's not very surprising. So all of you know probably that we have one of the most performant research reactors, the BR2, producing for a long time already molybdenum as one of the basic diagnostic radioisotopes, but not the only one. Of course, we have also lutetium-177 and many others. So that's one of the reasons why we entered into this domain. Now, this domain has several challenges, and I think also the other speakers will talk about it. It's on one hand the supply, so the basic supply, the supply chain, but also on the regulatory aspects, several things need to be changed in order to get a fruitful implementation of this new therapy worldwide. And of course, infrastructure and supporting R&D is needed to get there. Now, if you look to the research reactors, there are not so many in the world. If you look to the demand, even if we look at the new planned reactors for the time being, excluding Palas, but of course, we hope it will be there in order to accommodate, let's say, the increasing demand. So there is still a challenge on, let's say, the primary side of the existing reactors. It's only part of the story, because we know that a lot of the other radioisotopes are going to be produced by accelerators. But there, of course, you also need the necessary infrastructures. Now, on one hand, you have the reactors, you have the accelerators. That's, in fact, the irradiation part. But it's not the only part that you need. You also need the starting material, which for many of these radioisotopes are also quite rare elements. And in the past, you didn't have many suppliers for that. Whether you talk about actinium-225, the starting material is radium-226. It's something in a very pure form that is readily available. But okay, we will talk about it later. We have also, let's say, historic stocks about that. Then you come, of course, with the separation techniques. Separation techniques, which, of course, includes recycling. Today, you're not going to throw away the very rare basic material, so you will recycle. So all these techniques needs to be developed. You need the infrastructure for that, and this is also something that needs to come online. And then, of course, you have radio labeling, distribution, and the rest. And at the end, of course, you need the national policies. Now, you see here that analysis that was done at the level of about what is the status of all these different components. And you see gaps that are appearing that we need to fill in order to, let's say, have a wide distribution of these radioisotopes towards the future. This is just an extract. You can find the entire document on the web. Now, also on the regulatory side, a lot of initiatives have been taken in the past, but it's something that we need to pursue in the future. This is just an overview of what we have been doing at European level, but also at national level. If you look to the targets are abundant, but the vectors are mainly small molecules and peptides. So this is something that we are also at SCK looking at in order to progress also in that domain. Now, coming back to Belgium, how are we trying to address that? We have several assets in Belgium. So we have federal institutes like SCK-CEN, IAEA. We have a lot of hospitals that are renowned for their cancer research, also in this domain with these type of radioisotopes. We have a large pharma industry. We have technology providers. We have transport companies. So the Belgian ecosystem is specifically well placed to address, let's say, this new development area of targeted radiotherapy. So, and this goes from R&D to results. Maybe if you look to, let's say, one of the elements, patient care, also there, things need to be changed. At the level of the hospitals, you need to foresee the necessary infrastructure. Also, that is important. All these elements are things that we are addressing in the RLT for Belgian initiative, where we group the different stakeholders together to look at what are the gaps in this ecosystem, how can we fill it, and how can we, let's say, get to a fruitful implementation of this type of technology. Here you see all the stakeholders that are, let's say, involved. You see many organizations coming together around one action plan that we have developed for Belgium. So RLT for Belgium. So you see all the ecosystem that you see here is pulling its resources together to identify the gaps and to identify the necessary actions to go forward. Now, at SCK, we are part of this ecosystem. We're also having our own strategy or our own contribution. First of all, in the area of supply of medical radioisotopes. Not only, let's say, the bare material, something that we have been doing traditionally, but also going one step further, separation, recycling, into GMP conditions. This is some new ambition that we have. In the past, it's not something that we have been doing, but this is one of the ambitions that we have. Of course, we are also going to address the efficiency and safety of radiopharmaceuticals. This is something based on the expertise that also was available at SCK, but we are pulling them together and together with the groups of radiobiology, radiopharmacy, and so on. We also looking into the deeper understanding of the underlying mechanisms so that we pull all the resources together to have, let's say, a coherent strategy in the domain of radiotherapy. What are the domains of cancer research that we are focusing on? It is glioblastoma, ovarian cancer, and colorectal cancer. So we have tried to make a choice. It's not easy because some of them are, let's say, addressing more rare cancers that are not so obvious, and success is not guaranteed. But as public foundation, and we also want to address some of these more rare cancer types. So what are the isotopes that we focus on? Lutetium-177, terbium-161, and actinium-225. So those are the ones for the time being that we try to focus on. And either we do that alone or in partnerships. So with regard to lutetium-177, this is in partnership with IAEA. And for actinium-225, we even created a new spin-off, which is called PanTera, and Sven will talk about that a little bit more. So where are we constructing these facilities? At our SCK-CEN site. So here you have an overview of the site. The first facility that we constructed was HAF. It's called Hot Animal Facility. It's not because it's hot, but it's because it's nuclear. So it means that it's a very expensive hotel for mice, where you can inject them with radioisotopes to look to the behavior and so on. So this is a new facility that we built. It's operational in the frame of, let's say, the preclinical research that we do in support of this therapy. Then we have now also completed the construction of the so-called CRF. It's a centralized radiochemistry facility. It has lines for the production of, for instance, lutetium-177 in GMP conditions, so the separation and recycling. It's also the first time that in SCK we go into GMP. So this is a new facility. Yeah, I'm almost done. We also have partnerships with external partners for a radio labeling facility that will come next year. And then, of course, as Sven will explain a little bit more in detail, we have just on the outside of our fence, we have sold a land to the legal entity PanTera, which is a joint venture between SCK-CEN and IBA for the large-scale production of actinium-225. So this is the ecosystem that we are, let's say, also creating at SCK and how we are facilitating, let's say, this new type of therapy. Thank you.
Thank you very much, Peter. I would now like to ask Sven van den Bergen, who is the CEO of PanTera. As already said by Peter, PanTera is an organization that was created out from SCK-CEN and from IBA, and he will tell us how PanTera can give us really opportunities to fight for life.
This is better. Yes, this is better. I can also shout if you would like that. Indeed, PanTera, we are a company that is now 3 years old. I still have trouble saying 3. It always feels like 4 or 5 already. But we were created to produce large quantities of the actinium-225 isotope, one of the promising isotopes for the future. And in general, the promise of radioligand therapy is something that I've been passionate about since I started seeing images such as these. You don't have to be a radiologist to see that the person on the left has an issue. All of the black spots are metastases of cancer, in this case prostate cancer, and you also don't have to be a radiologist to see that the person on the right, of course the same person, is looking a lot better, and this is thanks to radioligand therapy. In this case, it is lutetium-177, the Pluvicto, which is an approved medication and is today being administered across the world. But for tomorrow, we're looking at actinium-225 as a follow-up for lutetium-177. Why? Because it is an alpha emitter. It deposits its energy over a much shorter range, 1 to 2 human cells instead of the 100 cells of the beta emitter. And it causes, on almost all cases, a double-strand break of your DNA, of that DNA, which is the bad DNA of the bad cancer cell, and so therefore causes it to die. Instead of potentially causing damage to the cell, which can then still be repaired. And you can see that even in some cases where patients no longer respond to lutetium PSMA, in this case it's again prostate cancer. Sorry for the ladies, there's a lot of research and a lot of results on prostate cancer because of course the population is there and the unmet need is there. But if the patient no longer responds to the lutetium-177 PSMA treatment, an actinium treatment can follow, and you can see the dramatic results that are there. By the way, this image, many of you will say, oh, I've seen this hundreds of times. For those that haven't seen it before, this was actually the very first patient ever treated. We've done that here in Europe, in Karlsruhe. Some people from Karlsruhe are here in the JRC. That was the very first patient treated, and I can only imagine the amazement of the doctors that saw these images. So this is the promise that they followed through. Now, there's also practical aspects to why actinium-225 is a great isotope for the future. It has a 10-day half-life, which is ideally suited for centralized production. And this is a very neat one, it has very similar chemistry to lutetium. So all of those clinical trials, and there are hundreds ongoing, with lutetium are likely to get, at least those that get through that gruesome selection, are likely to get a brother or sister with actinium-225. So very important. Already today, and this slide is a little older, I say thousands of patients treated. I don't know exactly, maybe Rebecca can say more clearly, but certainly across the world there are now many thousands of patients that have been treated with actinium-based products, hundreds of preclinical studies, and definitely in different phases clinical trials ongoing. So what's the issue we are dealing with? Why don't we just create a lot of actinium and do this? Well, actinium is not an easy product to create, and its supply, its availability in the world is today rather low. You have, until a few years ago, just a few research sources, one once again in the Karlsruhe Institute, another one in the US, and there is also a Russian material that was available, but that was enough for a couple of thousand patients. Since then, we've already come quite a way, and a lot of new sources have been put online. One of them also, very proud of that, by PanTera in Belgium, and I'll talk about that later. We are right now the biggest provider of actinium-225 in Europe today. And we'll need it, because very soon, when clinical trials advance into a third phase, and especially when commercial products come onto the market, the demand for actinium will quickly go up. And if there's one thing we're not good at in the nuclear sector, it's moving fast. So we're preparing the moment that will happen. And we're expecting quickly to reach a demand of 50, 100, 200 curies per year. 1 millicurie is about the amount of actinium-225 you need, very variable, of course, from treatment to treatment, but it's about the amount you need to treat one patient. So the amount of millicuries is the amount of patients. And if you know that for each of the drugs that will come onto the market, you're usually looking at 20,000 to 100,000 patients, you quickly see the amount of actinium in demand going up. And creating that actinium is not an easy task, but we're up to it. And we're PanTera. We are created from SCK and IBA, and I want to explain the name a little bit. People think we're a rock band. I love that. I always say we didn't have to create the t-shirts, they were already on the market. But actually that was not the reason why we created that name. Pan is a prefix, of course, like in pandemic. It's an unfortunate way of getting to know that a couple of years ago, but also in Pantheon. So it means all-encompassing, and it links back to our value as a company to be an enabler. There's Terra in it, which is of course linked to therapy, but also to the earth. And so there, it links it to the value that we are dependable, very important as an isotope producer. And finally, there's also a Greek philosophy called PanTera, and that one says everything flows, you cannot get into the same river twice, and that is where our value as a game changer comes in. So we are PanTera, and we have, as one of the first actions we took in 2022, created an agreement with the US company TerraPower. TerraPower Isotopes, the department of the company dealing with the isotope production, actinium-225 on their side as well. It's a Bill Gates company that you might know from the Natrium reactor, and they're very, very busy with revolutionizing the energy system, but they're also into isotopes. And they have been able to lay their hands on the entire stock of thorium-229, one of the precursors for a production process for actinium-225. We've made a deal with them, and we now have in Belgium a small part of their thorium-229 into generators, thanks to the use of the SCK-CEN facilities that we are renting from them. We are now producing, and our first production was on June 12th, and since then, well, let's just say this is a week's production already, and we're increasing, so soon it won't fit the photograph anymore, and that will be a nice day. One of those boxes actually went, and I'm super proud of that, to Oncidium, and it went to New Zealand, and it was used to treat a patient. This material is, of course, for research use, but in case of a doctor's decision, it can be used to inject a patient, and Oncidium was in need of some actinium, and we were able to supply some of it. So today we have a patient, and I hope soon we will learn, 2 patients, thank you. So I hope soon we will learn how they are going with it, and you can imagine the motivation for the team that was. So from October, we will be able to supply about 135 millicuries, and as I said, that's 135 patients for 3 doses. So that means we'll be able to supply that every month. But the thorium generator, the thorium-229, is not enough, because the whole stock of thorium-229 that is available in the US will be able to produce about 50 curies per year, so about 50,000 patients per year, which obviously is great to support the clinical trials, but is not going far enough to support commercial use. So we've looked at other ways of producing actinium-225, and actually all of them start, all of the ones that produce actinium-225 in a pure form, they start from the special element, radium-226. And it just so happens that in Belgium we have a historic connection with radium-226, and there is a unique and I'm saying unique with confidence because I've traveled the world now looking for more radium, and there's not more radium like there is in Belgium. There's a unique stock of pure radium-226 at the SCK-CEN for historic reasons. On the other hand, you also need an accelerator, and we just happen to have in Belgium one of the world leaders in accelerator production. That is IBA. So bringing these two companies together, and we needed some money as well, so we went out and looked for investors, and there was a consortium that investors that believed in our story and was able to grant us 100 million of investment money. That all together creates the situation of PanTera today, which is we are a fully funded private company. We're funded up to profitability. We have an experimental hall that we just moved into. Very nice to do that too. And we will build components there. We will test components there. Those components, the engineering phase has been completed, and we're moving into the construction of the I would say prototypes, but it's more of the, let's say the initial types that we will test and then perhaps optimize a little bit. We are in early supply. As I said, we are delivering actinium today on a weekly basis. Our permits are there. Thank you, Frank, for assisting us there and working with us to get there. And we will start our facility, the construction of our large-scale production facility. Well, actually, it's been started because the trees have been cut, but we will officially start on the 2nd of October 2025 with our commissioning in 2026. And so what will we build? Build a facility for one rhodotron, so one accelerator, with 2 radiation stations for that rhodotron. As you can see in the upper left corner of our building, there's a piece cut out. Well, that piece fits another rhodotron and another 2 radiation stations. So that's for redundancy in the future. Already with the 2 radiation stations, one will be in use and one will be in maintenance. Very important. Many other would-be manufacturers of actinium-225 have not thought about maintenance, and it's crucial when we're doing irradiation, things with irradiation, since it will be difficult to access your components once they are activated. We will have room for 2 radiochemical separation lines. Again, we will build one and have the other one for redundancy as fast as possible. We'll have 3 dispensing rooms. We have 3 waste treatment hot cells, also very important. Many of our competitors do not immediately think about waste, and I do know how important that is. And because we're working with radium, not an easy element to work with, not an easy chemical to work with, it emits alpha particles, but it also decays into radon gas. We have a patent on a radon trap, and every hot cell that will deal with radium will have its own radon trap. In total, we will have in that facility up to 100 grams. Right now, we have 70 grams of radium in our assets. And we have a secured waste stream thanks to the fact that, and this is strange to say thanks to the fact, but Belgium's knowledge, which was a burden until recently and now is a big asset, is a great thing for us to have. Important for us, and then I will conclude, is that our technology has been set up in such a way, and this is because of the Belgian background and because of the SCK-CEN, because of the government regulatory organizations pushing us in that direction, to make this a sustainable process. That radium-226, it is unique. There's a lot, but it is finite. And we're not transforming any of the radium, well, we're not transforming real considerable quantities of that radium into actinium. The only way you can lose radium is by being not so careful in your process, by having losses in your process. We've designed our process not for the optimized yield, but for the optimized recycling of the radium. And we believe that is very important because we don't want to create a new radium problem in the future. Every radium you lose will end up in your waste, and that's not what we want to create for our children. We'd rather solve cancers than create new ones. I've already talked about the timeline, so I won't go over it again. But the important thing is that we're also looking from the moment we start up our facility and we start commissioning our facility to create additional multi-sourcing availability of our technology and moving that beyond our borders as an export product of the Belgian nuclear industry. So and we hope that brings new hope to the patients, and we're very proud to be part of it.
Thank you, Sven. I now would ask Rebecca to come forward. and then to tell us about the Oncidium Foundation.
Excellency, can you hear me? Excellency and distinguished delegates, it's my pleasure to be here today, not only to share the work of the Oncidium Foundation, but also to put the patients at the heart of our discussion. So the Oncidium Foundation is a non-profit organization dedicated in advancing access to radioligand therapy worldwide. So as we could hear from the previous presentation, targeted radionuclide therapy is also known under radioligand therapy or radiotheranostics. And it all refers to the same concept, which is using targeted molecules to deliver radiation directly into the tumor cell to destroy it without affecting the surrounding healthy tissues. So, as you can see, it brings a lot of hope for patients, and especially those who did not respond to the commonly used treatments. So you might think, okay, this is very promising, but why isn't it more widely used? And Sven, you mentioned thousands of patients, yes, but do you know how many in developing countries were treated? 0. So this is why we stand here, because the figures are scaring. Dr. May, you mentioned 10 million is the number of patients dying every year from cancer. And among these lives, a large portion could have been extended or even saved with the proper access to radioligand therapy. But then why is it? And on the Lancet Oncology Commission, a publication from last year, the barriers were mentioned. Access to radiopharmaceuticals is main problem. Production is complex. Regulation are strict. Logistics is complex as well. Lack of trained workforce. There are not enough workers properly trained to handle and produce and administer these therapies. Not enough infrastructure. The healthcare infrastructure are not equipped with this kind of equipment. And lastly, the costs are high and reimbursement is limited. And for a few years now, the Oncidium Foundation is trying to tackling those problems. And then we organize our activities around 3 pillars that are access, education, and hope. And we strongly believe that creating this virtuous circle while bringing more education will lead to more hope, that will lead to more access, and so on, is really the way to go. And before going into more details on this, I would like you to meet Malena. Malena, she lives in Buenos Aires, and she is 16 years old when she's diagnosed with a neuroblastoma. And since she was diagnosed, her parents and herself, they need to start fighting against cancer, but also fighting to get access to life-saving treatments. And I'd like you to listen to her story.
Finales, yo empecé con mucho dolor en las piernas. Hice una ecografía y con la ecografía se descubre el tumor y que tenía, con más estudios, que tenía rota la espalda, que tenía mucho daño. Entonces, ellos al recibir la noticia de que era cáncer, un neuroblastoma, el primer ciclo de quimio, que fueron 8 sesiones, después tuve la cirugía, en la que sacaron gran parte del tumor, pero no todo. Pues seguí con una segunda línea de quimio, que es así, hizo que me sintiera mal y tuve que volver varias veces a internarme porque o levantaba fiebre o se complicaba la situación. Y después empecé inmunoterapia, que también era experimental. Cuando tuve la segunda, aprovecharon y quisieron hacer la segunda cirugía para ver si se podía expresar todo el tumor. En la cirugía se complicó y perdí un riñón. Yo venía un poco harta de las quimioterapias, no quería hacer más, hasta que un día alguien me abrazó con un cariño y dije, ¿qué te María? Así que cuando me hablaron de esta posibilidad, dije, bueno, está bien. Quise que me explicaran un poco porque la verdad es que no hay mucha información al respecto, pero me lo explicaron y al ver que era con Bastianello dije sí. Al principio apenas se planteó la posibilidad sí, porque había que tratarlo con la obra social y la obra social siempre se niega a cualquier tipo de tratamientos y más hasta que Bastianello llegó en Chile a las primeras dosis y después nos preocupamos del resto. Y cuando vi que había funcionado, dije, bueno, aún sí que se encarga, esto es tan importante. Me imagino en unos meses con un alta, ahorrando lo suficiente para poder viajar y conocer un poco más el mundo. Y que esto no es todo, hay mucho más, porque siempre hay fundaciones como Oncidium que te pueden ayudar a llegar a más tratamientos. Muchas gracias a ustedes.
Well, the story of Malena, I have to confess, is very close to my heart because she is approximately the same age as my own daughters. And honestly, I don't know how I would feel if I would face such a situation, but very luckily, Malena is strong and she's doing well now. So I'm very happy to share that with you. Let's go back to our pillars. If you remember, access, education, and hope. So in terms of access, at the Oncidium Foundation, we believe that that's local action that matters. So we have developed this network of ambassadors. So they are volunteers, experts in radioligand therapy, and they help us achieve our global mission at a local level. I'm very proud to say that today the Oncidium Foundation is present in more than 70 countries in the world. Also in terms of access, and this is to help patients finding where to get treated, we have this tool on our website where 1,000 of treatment centers, they did register, and this is helping patients finding where to get treated, finding the best treatment center according to their disease with the direct contact information. And this has been demonstrated to be very helpful for them. And if we go to our next pillar, education, we have three audiences here. We create educational content for the patients and the patients' associations, for the healthcare practitioners, and also for the nuclear medicine community. So we create specific content for all of these audience through specific media. And here are a few examples. You can see on the table the Mr. Bine and his companions on their life-saving missions. This is a project that we have achieved in collaboration with Dr. Jérémy Calais from UCLA, and it's answering patient questions and also demystifying what is radioligand therapy and reducing the fear of it. It has been now translated in more than 20 languages and distributed all over the world with a very impactful result. We also have on YouTube our RT channel with more detailed content for the patient, also with a lot of success. And for the nuclear medicine community, we publish regularly the Radiotheranostics Today magazine, the Radiotheranostics Inside, with high-level and neutral content for the community. In terms of events, we organize such an event like the Theranostics event, regional Theranostics event, to motivate the oncology community to propose and offer radioligand therapy in the region. And I take the opportunity to invite all of you to join the Tackle Cancer Challenge that will start in 2 weeks from now in collaboration with the ENM. And it's a collaborative sport activity that you register on an app. And for 3 weeks, the objective is to reach the largest distance altogether. Let's now move to our last pillar, hope. And before diving into it, because I feel it's the most important, I'd like you to meet Fernando. Fernando also lives in Buenos Aires. And if we go back in time, in 2018, he starts feeling some symptoms. And he was very happily living with his wife, Marisa, his 2 sons, Lucas and Facundo, and even his granddaughter, Ambar. So he decided to go to the hospital and check about those symptoms. Let's discover his story.
En el año 2018, IAEA se diagnosticó un adenocarcinoma metastásico en estadio Gleason 9, no quirúrgico, invasivo, y me tuvo 4 meses internado con muchas complicaciones. Esta noticia para mí fue devastadora. La enfermedad siguió progresando y un día me dice Fernando, mañana comenzás con radioterapia intensa, conformada, tridimensional, de 25 sesiones. Yo estaba muy dolorido, estaba muy mal. Tras 25 días de sesiones, continúan con un plan quimioterápico, llegando así a 42 sesiones de quimioterapia. Yo no sabía qué más hacer. Mi oncólogo me cuenta la posibilidad de hacer un tratamiento con lutecio.
So we are back in this hospital room 3 years after his diagnosis, and Fernando was in so much pain. And his doctor came to the room and said, Fernando, there is a possible treatment for you, lutetium-177 PSMA. Sounds like a good news, isn't it? But not really, because his social security, the Obra Social, refused to cover for this treatment, to pay for this treatment. And even though Fernando is a doctor, he's a veteran from the Falcon War, it was impossible for him to cover the costs. It's way above what usual people can afford. But Fernando didn't let him go, and let's see what happens next.
Y averiguo, la obra social no cubría este tratamiento. Tuve que movilizarme mucho, reunir muchas firmas. Logré reunir 75.000 firmas y tras esto logré la Fundación Oncidium se comunicara conmigo y me diera cuenta de que sí o sí yo iba a recibir este tratamiento nuevo.
So indeed, you heard that Fernando says the Oncidium Foundation reached out to me. But how come that we could reach out to him? It was thanks to our local ambassador that I mentioned earlier. Our Argentinian ambassador, Guillermo Casale, got to know about this case through this petition. And this is how he reached out to us and we could help him. And let's see the end of the story.
Me hicieron la segunda aplicación y tras la cámara gamma posterior a eso se vio que la enfermedad había retrotraído bastante y había esperado una dosis. Hace 4 semanas me apliqué la tercera dosis y el barrido de cámara gamma posterior dio cuenta de que ya no había captación del radionucleido de la droga. radioactiva, lo cual nos hizo tremendamente felices. Pero yo he podido desarrollar una vida normal, he podido de a poco reincorporarme a la sociedad, a mi entorno, a mis tareas, y no he tenido efectos adversos ni complicaciones importantes.
And there is even a cherry on the cake with this story. Thanks to his petition, now the Obra Social accepted to reimburse the treatment for lutetium-177 PSMA in case of prostate cancer. So we were, of course, overjoyed, knowing that Fernando is doing much better, but we were thinking, how about all other Fernando out there who didn't have the chance to meet a Maria or to meet a Guillermo? We wanted to act at a much larger scale. And this is how we decided to create RLT Connect. And it's a treatment donation program designed for underprivileged patients in countries where there is no reimbursement. So basically, it's a web platform where the nuclear physician, they will submit the case of their patients. And on the other hand, we create a match with pharmaceuticals companies who accepted to donate doses for those patients. And in order to define priorities, we create this tool in collaboration with our ambassador to define the readiness of each country and which country we should address first. And I'm very proud to announce that we are now able, so this tool is operational in more than 19 countries. So we create the ecosystem in 19 countries. And in less than 2 years, we've been able to administer 160 doses, helping 62 patients in more than 13 countries. And we have set our 7 objectives for the coming 5 years to donate 2,000 doses for the patients in need. And here are some pictures we keep receiving on patients we've been able to support, and this is probably what passionates me the most. I'm closing here, thanking the supporting companies of the Oncidium Foundation, and I thank you very much for your attention.
Thank you, Rebecca. I now would like to ask Professor Le Villain to give his speech on the Jules Bordet Institute that's in fact shaping the future of radio-targeted therapies.
Yeah. Good afternoon, ladies and gentlemen. It's my pleasure to be here with you today to illustrate how the Institute Jules Bordet, and we are not the only one, are aiming to shape the future of radiopharmaceutical therapy. Up. No. Yeah. So I think you are all experts now about how a radiopharmaceutical works. But basically, as you understood, we need an isotope that can be used or as imaging or therapy agent, coupled with a vector that will target a specific behavior of a tumoral cell or an organ if you want to know the function of the organ. And so by switching the isotope for imaging and therapy, we are entering into the theranostic concept where we can treat what we see based on the diagnostic and see what we treat based on the therapeutic isotope. So now, as you understood from the previous presentation, we are really entering into the theranostic revolution because the nuclear medicine specialty that was historically diagnostic modalities is now getting more and more into the therapeutic aspect. And so it's now really a focus within the oncology pipeline with more and more radiopharmaceuticals that are arriving for therapeutic and diagnostic. And we are now facing really a tsunami of radiopharmaceutical. And so this transformation requires a new ecosystem. We need new infrastructure for clinical and industrial purposes. as it was explained in the previous presentation. We need really to reinforce the multidisciplinary aspect of our team within the hospital, but also outside the hospital. And we need also to work on education, training, and on regulatory alignment. So the potential of radiopharmaceutical therapy is clear, but translating the innovation into access remains a global challenge. You have on the left side of this slide small vision of what this tsunami is. And you have here, in fact, all the compounds from the industries that are entering phase 1, phase 2, phase 3, and we hope arrive in the center of the figure where we have currently the lutetium PSMA for treating prostate cancer patient and lutetium PRT for treating neuroendocrine tumor. But faced to these opportunities, we have also a lot of challenges at the world and European level. We need to ensure the strategic autonomy in the therapeutic isotope production, and this was well explained in the previous presentation. We need to build a robust and integrated supply chain to have a hospital ready with all the infrastructure, the trained staff, and the safety protocol. And we need also to have regulatory harmonization across border, because this also can limit from country to country the access to radiopharmaceutical therapy. In Belgium, as it was also explained, we are in a very good position with the Belgium Radiopharma Valley, where in fact we are in a unique position because we have players around the entire value chain, going from the isotope production, the transport, the running of the clinical trial, treating the patient, but also on the regulatory aspect. But even though we are in a very good position, there is still strategic challenges. We need to broaden the hospital readiness beyond reference center. We need to strengthen the national coordination to maximize the effort and the impact. And there is also already the radioligand therapy for Belgium initiative that really is going into that sense. And we need to ensure long-term sustainability of expertise and infrastructure. So we have all the building block, but we really need to put them all together to reinforce this ecosystem. If we focus now on what we try to do at Jules Bordet Institute, which is now part of the University Hospital of Brussels, present at the Erasmus campus, where we are working on developing the theranostic concept since 10, 15 years, and we beneficiated for substantial funding from the foundation, the Association Jules Bordet and the Association Vincent Nuclear, who really provided a lot of funds for research development. And so we were able to build a theranostic center of excellence that cover area going from preclinical research to isotope production only for diagnostic at that moment. We have a GMP radiopharmacy, one of the unique radiopharmacy GMP in Belgium. We have, of course, state-of-the-art equipment for molecular imaging. We have a very strong team in medical physics, also in clinical trial operation team. And we have dedicated hospitalization rooms, because for treating patients for lutetium PSMA or PRT in Belgium, we need dedicated hospitalization rooms, and not all the centers have those rooms. So thanks to all this equipment, we are able to cover the value chain of developing a new radiopharmaceutical, going from identifying targets and developing radiopharmaceutical, also running the preclinical in vitro and in vivo experiment until arriving to phase 1 and phase 2 trials. And so in our center, we have currently, and in the pipeline, 29 trials. And as I said, we are also highly specialized into conducting phase 1 clinical trial for radioligand therapy, because running a phase 1 also requires a specific infrastructure. And this is because we have a very strong multidisciplinary team working together. So we have here on the right side of the slide a representation of the number of clinical trial per indication and per isotopes. And the color is changing because it's our industry or the trials that we are sponsoring. And so what you can see is that the main indication of our application are in fact the prostate cancer and the breast cancer, but we are also starting some very interesting trial on other type of cancer. And regarding the compound, we have of course most of the trial focusing on lutetium 177, but we are also now starting to work on alpha emitting isotope with actinium 225, as it was mentioned in the presentation before, but also on lead-212 and astatine 211. So how can we go from our local expertise to a global action? Well, we have several initiatives. First, we are collaborating with the IAEA through the Technical and Cooperation Initiative. We have several people from our staff that are technical experts, and we are also working with the Oncidium Foundation as ambassador. So we were very pleased to hear this initiative of joining forces between Oncidium and the IAEA, because we think that it's really going into the good direction. And on top of this, we also try to develop new initiatives. Recently, in fact, last year, we obtained two European project, the Accelerate.eu project and the Terra4Care project, and specifically for the Accelerate.eu project. And I'm pleased to see some friends around the table that are participating to Accelerate. Here, really, this 60 million initiative aim to reach strategic EU autonomy and greater patient access to alpha therapy. And in this project, we are focusing on astatine 211 that can be produced through accelerators. So we are in a decentralized production way, which is very complementary to the centralized approach with actinium 225. And so in this project, we aim to target 3 unmet clinical needs with pancreatic cancer, glioblastoma patients, and triple negative breast cancer. So to finish, really to go to unlock the global potential of radiopharmaceutical therapy, we think that we need a coordinated ecosystem approach where production and supply chain together with expert center network and global partnership and enablers like the IAEA and the Oncidium Foundation will allow to move from innovation to clinical readiness and global access. So with this, I would like to thank you once again for your invitation and for your attention. Thank you very much.
Thank you, Professor Villain. Now, I would like to give the word to Diana Paes to tell us about the work that's being here at the agency on the RLT technology.
So can you hear me well? It is a privilege for me to be here today. We have heard 4 outstanding presentations. Now I will talk about the role of the IAEA in supporting all the things that we have seen. So my talk will be basically how can we connect the dots? How can we connect the targeted radionuclide therapies with the Raise Up Hope initiative? Thank you. We started with the diagnostic imaging. It was mentioned how PET-CT, SPECT-CT, they will help us to diagnose the patients. We have been doing that for years. Now we are going to theranostics. It was beautifully explained by Rebecca how we combine the same molecule with different isotope to do the diagnostic imaging and the therapy component. This is basically the yin and yang of what is called personalized medicine. This is what we are doing. We also mentioned that we have several challenges. Limited production capacity, supply chain logistics is very complex. Regulatory compliance, too many regulations, so difficult to comply with. Cost and reimbursement, high cost, no reimbursement. Research and development, how many trials did you mention, doctor? 200? So we are doing a lot of research, but it's very costly and is limited. Safety and quality. We have to ensure that whatever we do is safe and it has high quality. Education and training, it was mentioned in one of the pillars of Rebecca, so it's also extremely important. To tackle that, we need a multi-sectorial approach. all of us working together, governments, Belgium, NGOs, non-profit organizations, UN organizations, IAEA, to be able to support this. From the IAEA side, we definitely have a multifaceted, multidisciplinary support. There are so many departments, divisions, and sections working together. Let's start with the Division of Human Health. We have our director here, Dr. May Abdel Wahab, and I am from the Nuclear Medicine and Diagnostic Imaging section. We take care of the clinical applications. We support the clinicians, the nuclear physicians, the radiologists, the technologists. We work hand in hand with the physicists to make sure that we provide proper dosimetry, equipment calibration. This is the Division of Human Health. Then, as part of the same department of the nuclear applications, we have the colleagues from the radioisotope products and radiation technology. We have Aruna here. They help us with the production of the radioisotopes, cyclotrons, radiopharmaceuticals. They are part of the Department of Nuclear Sciences and Applications. Then we have the colleagues from Nuclear Safety and Security. There are several units. I would like to highlight basically the radiation protection unit of patients that will support us to make sure that whatever we do is safe for the patients, for the staff, and for the environment. And we have, of course, the colleagues from technical cooperation that will support with the implementation arm. We have seen the numbers. What the agency can do, we have data. One of our main initiatives is the Imagine database that was launched on the occasion of the Lancet Oncology Commission in 2021. In the Imagine database, we have data about the availability of equipment, availability of staff, and it was pointed out by Dr. Abdel Wahab and by Rebecca. Access is not homogeneous. These are the number of SPECT and PET scanners that we have globally based on our database, and we keep this information updated. I would like to highlight only one number. One PET scanner in a high-income country covers 250,000 people, more or less. The same scanner in a low-income country covers 250 million, no thousands. So we don't have access. Agency keeps data in order to be able to advise our member states. Availability of radiopharmaceuticals. We heard about PanTera, CA-CEN producing. Now, how about from the user side? For the Lancet Oncology Commission on Radiotherapy and Theranostics that was launched last year, we did a survey with 105 countries where we were looking at the consumer, the use of the radioisotopes, and those are the numbers. So we need to be able to supply this. However, we have seen that this is not so easy. And if it is available, then the cost is prohibited. The agency keeps track of the reactors with the colleagues from nuclear NAPC and the reactors, they keep track of the number of nuclear reactors that are used to produce isotopes. And I must say that Belgium is one of the champions in the production. We keep track of the cyclotrons that are available. All this data is available. You can see there the QR codes, and the presentation will be available for you to get more detail of what we have available at the IAEA. Then how about the safety and quality? Dr. Wahab already mentioned that. We have safety standards to help comply with the safety that should be associated to the practice. We have information about how to transport, how to manage the waste, and we definitely have something that is encompassing everything that is the quality management. This is the good news. Thanks to the support of the IAEA and some of the initiatives that were led in the Division of Human Health, we were able to have the World Health Assembly resolution that was in May 2025. For the first time in forever, we have a resolution that mentions that having access to medical imaging, including nuclear medicine for diagnostic and therapy, is a must. So this resolution is something that can be used with our regulators, with our policymakers, because for the first time, the WHO recognized the essential role of medical imaging for the management, not only of cancer, other non-communicable diseases, injuries. The person that you can see here is Dr. Andrew Scott from Australia. That was one of the lead authors of the Lancet Oncology Commissions, and he was the one behind the proposal. So this resolution built on the previous resolutions that the agency was also involved on that, and the two Lancet Oncology Commissions that I have mentioned before. The first one is this one, very important. For the first time also, we were able to come together 17 professional organizations led by the IAEA to show that not only investing in imaging and proper therapy will save lives, more or less 2.5 to 9.6 million lives by 2030, but also the net benefit is in the order of trillions. If we invest properly, we will have $2.5 trillion. And the return of investment will be of approximately $13 per dollar invested. This is the only way that we can talk to our governments. Then we had the Lancet Oncology Commission on Radiotherapy and Theranostics that was also mentioned. How can we connect this? How can we connect the dots? We have the Rays of Hope. Rays of Hope is one of the IAEA flagship initiatives that was released a couple of years ago by our Director General, and the goal is to improve access to cancer management, the radiation medicine application, radiology, radiotherapy, nuclear medicine in a context of quality. So it is very important to have our pillars sustainable, supporting access, supporting research and innovation. As of now, we have had 95 or perhaps even more requests to join. This is for the recipient countries, recipient of technology transfer, capacity building. On the other hand, we have these anchor centers, which are regional hubs for education and training. Oncidium can support the anchor centers so they can support the regions. So Lilian, how many we signed this time? 5? 6? So this morning we signed 6 new centers. So we have in total 17? 18, and it's growing. So with that, I would like to conclude and mention that we share a common goal. We share a common goal of having radiotheranostics available. We have a common share of having access, education, and hope. And I thank you so much for your attention.
Thank you very much, Diana. We are running a little bit out of time. We still have about 15 minutes for the panel. And as Luis Longario could not be here, we have May who will lead the panel. And the speakers for the panel are sitting a little bit around us. I don't know whether you want to introduce them. Of course, the speakers of today, and then besides speakers of today, we have Lisa, who is sitting here, and Tsanka had to apologize because she had to go. So May, the floor is yours.
Thank you very much. So can you hear me now? Okay. Time is kind of tight, so we'll have some general questions, but we'll start out with Rebecca. And we know that the Oncidium Foundation has signed, as you heard, an agreement with IAEA in the context of Rays of Hope. So as CEO, what concrete milestones do you foresee in the next 12 to 24 months? And how do you see the success measured? Because it's really important to be able to track that.
Thank you for the question. So we didn't wait for this collaboration agreement to be signed before starting our activities. And together with IAEA, we've been able to already achieve a few projects. One of them is the training in Nigeria in July for QC and labeling that led to the administration of the 2 first patients in the country. Thanks to this collaboration. So the country is now ready to properly treat the patient in the country. We have 2 projects that has already been approved by IAEA that we collaborate. One is in Kenya, for the development of a comprehensive and integrated nuclear medicine department. Another is in North Macedonia for the establishment of a theranostic department. We also collaborate with the IAEA on a clinical trial in South Africa for pediatric neuroblastoma. Providing the treatment, and all in this is integrated within our RT Connect program. So in terms of measurement, and thank you for the question, I like it very much. For us, the success is a number of lives we've been able to touch and to support by providing the doses. It's also, and I show you the maturity level map that we have designed, is how many countries moved from a maturity level to a higher maturity. How many countries could have started reimbursement or enhancing the reimbursement in terms of RT, and also the number of centers we've been able to train so they can have a direct impact in treating patients.
Fantastic. Thank you. Very good markers there. So as we move forward, this question is for all our Belgian representatives, so Hugo, Peter, and Sven. And how do you think Belgian institutes are going to be able to support industry, of course, this partnership as we move forward?
So I think that we are already participating, as I said, to some initiative from the IAEA and Oncidium Foundation, but I think we really have to accelerate this partnership and to extend beyond the medical institution, but also for industry to really have a representation of all the expert of this value chain that can then go to different countries and really train all those people to get there.
Capacity building. Thank you very much.
I think as we have been showing, we have already been trying to put all, let's say, the actors that are, let's say, currently working in Belgium together and making a plan and defining the gaps that are still there. And I think it's a very interesting journey that we are going through because maybe 3-4 years ago, we didn't know each other as well as we do now, and especially because we are from SCK-CEN, the research center, and so we are coming from a background that is more in, let's say, nuclear energy and radioisotope production, and so we are moving up into the value chain and also coming closer to, let's say, the patients. That's not our field of competence, so we need to partner there with, let's say, the hospitals in Belgium, and also looking to the indications and where we can find, let's say, the best, let's say, partners, because we really have to look to the partners to go to the patient in the end, but also on the let's say the front end, look for the production to the right partners, because you cannot do anything alone. And that's also what we have been doing in the past, either with IRE or with IBA or whatever. I think this is important. Also for the starting material, we also have to look for the right partners, because all these gaps need to be filled.
Very good. Thank you.
Maybe what I can add is that we are in a unique situation today with respect to where radioligand therapy is. It has had a false start. For those of you that remember Bexar and Zevalin, those were medications that have tried to start this. It was not the right conditions. We're in quite a different situation now. Industry is there, investments are there, big pharma is there, and so we're really starting this off. We still have to be careful because interest cannot be lost. And what we also have to be careful of is that a lot of the innovation is being done in countries like Belgium, in regions like Europe, but we tend to have difficulties maintaining afterwards that innovation within Europe. Yes, I know this is the IAEA, it's global. So as long as we're helping patients, that's great. But we need to make sure that some of that innovation also gets the feedback or gets developed into an industrial application within Europe. So making sure that the public money that is being made available is going to the right places and not to the most sexy places, not to those that are lobbying the best, but really going to where it matters most for the patient is, I think, very important. And preparing that healthcare system across the world actually is where a challenge will still be. And that's where public money will be most needed.
Wonderful. Thank you very much for that. Very insightful. So now we'll move to our IAEA colleagues, our two colleagues, Lisa and Diana. So how do you see the agency envisioning Belgian efforts in empowering Rays of Hope across the globe? How will they help Rays of Hope? And do you think the partnership for the Oncidium Foundation can help in this matter?
Okay. Please, Lisa, go ahead.
Yeah, thank you so much. So it's been really interesting to sit and listen, and I think, you know, Diana opened the door with her presentation talking about what's happening on the technical side. But I'd just like to speak from the technical cooperation contributions to Rays of Hope and working closely with the NA colleagues. So Rays of Hope has really given, you know, shine that light on all of the agency's activities in radiation medicine. And we've seen an increase in requests from countries that are participating in Rays of Hope, not only in, you know, radiotherapy and radiology, but also as some of these advances in radioligand therapies have come on board. And we know specifically we've seen requests in Africa and Asia really rising, not only in cyclotron, you know, requests for cyclotrons, but really education and how to develop their own production in radiopharmacy, nuclear medicine physicians and trainings, nuclear medicine centers. So it's that, you know, that diagnostic paired with the treatment, and also in the QA and QC services that Diana mentioned. So I think it's really important, you know, partners like Oncidium, like the institutions in Belgium, can really cooperate with us as we meet these needs and requests from the member states. And one other thing I'd like to add is that countries are coming to us also for these baseline cancer assessments, these impact reviews. And we've recently had countries say to us, you know, we want to place a new cyclotron, and we would like the scientific expertise of the agency in the location of that cyclotron and maybe in some of the research. So there are lots of opportunities, I think, to collaborate under Rays of Hope from the presentations today. So I look forward to that.
Thank you, Lisa. As it was pointed out, we share the same vision, centered in education, hope, and access. And I think this is the way we can partner together in the three main pillars that Oncidium Foundation has, that are the same pillars that we have in the Rays of Hope. Education and training. Rebecca mentioned we have the entire community, referring physicians, experts in radiation medicine, public, patients, regulatory authorities. We can do it together. Access. We have data, they have data. We can share our data and make sure where the things are needed, which is also, as Lisa mentioned, part of the impact fact-finding missions. Hope. Making the doses available where they are most needed. This is one thing that we are lagging. And with the agency expertise, we can support Oncidium to let them know if the countries are ready to receive the dose, because what we don't want to have is to have one dose in customs somewhere in the middle of Bolivia, because they don't have. So those are the things that we can really do together. So cooperation in all the areas is the thing that we can envision. Thank you, May.
Thank you very much, Diana. Are we at time? So we'll avoid the last question then. And we'll go straight to.
I think we
to
probably have to conclude, because I know that the room should be free at 4:30, so people are waiting outside. So just please let me conclude. I think the idea of creating the Oncidium Foundation was also to have a big social value. And I think this was one of the main ideas that we had in the beginning when we started it. The initial idea was to create therapies or to find medication for people who didn't have access, but also in another way, there were a number of diseases that could have access through radioisotopes, but the amount of people that were concerned with that disease was not enough to develop the nuclear medicine. And this was our first concern when we started this organization in 2011. We turned a little bit around. We have the possibilities now. We have also financial access possibilities. And I think it's very worthwhile that we already obtained a lot of results, but the societal value cannot be underestimated. We really would like to reach every patient. We know this is a goal and this is not easy, and economic value, competition, everything is concerned. But for us, it's the patient that counts. It's the people that need it, that are. I also think that this is the basis on which we made the agreement with the agency a few days ago. So thank you for your attention. First of all, I would like to thank, of course, our ambassador for being here and for opening this session, also for all the support we got from you in order to prepare the event. I'd like to thank all the speakers and also, of course, all the supporting people that we needed, and there especially Ephraim, because from Oncidium he did a lot of work. And then I don't know all the names of the people from IAEA, but I know that it went also quite smoothly. So thank you all. And if you have questions, please just contact us and we'll see how we can help. Thank you.
Very good. Thank you.